කුලපති ස්වාමීන්ද්‍රයන් වහන්සේ සේවාර්ජිත මහාචාර්ය නාරද වර්ණසූරිය මහතාට උපාධි ප්‍රදානෝත්සව දේශනය පවත්වන මෙන් ගෞරවයෙන් ආරාධනා කරමි.
Venerable Chancellor, Venerable Member of the Clergy, Vice Chancellor, Deans of Faculties, members of the Council, other academic staff, graduates and parents and ladies and gentlemen. It is a great honor and a pleasure to be with you once again at the annual convocation of this great institution of higher learning, with which I had the good fortune to be intimately associated during the last 20 years of my life. To me, they have been the most fulfilling and rewarding years professionally, and in the eve of my career, there is no greater honor that I hold dear to my heart than being identified as an Emeritus Professor of this vibrantly thriving center of learning. Of course, you have made it quite clear to me that Emeritus does not mean retired, and since my retirement in 2009, I have been invited to contribute intellectually on many an occasion. As a lifelong learner, it is heartening to know that there are imaginative and innovative academics who are at the peak of their career, who feel that retirees like us can play a complementary role in motivating the young minds who are in their care at present. I must specifically thank your dynamic Vice Chancellor and the equally dynamic Dean of the Faculty of Medical Sciences and the rest of the faculty for having invited me. Since receiving this invitation, I have thought deeply as to the topic on which I should talk to you. After careful consideration, I have chosen the topic social accountability of the health professional. There are 3 reasons for choosing this topic. It has been a topic close to my heart, and I sincerely feel that I have done justice to it both in precept and practice. I have always taken social accountability to be a cardinal consideration, overriding all other considerations, including professional success. Many young health professionals are not quite conversant with what it means, as most curricula have only paid lip service to it, and that too in a theoretical context. This is in spite of the recent emphasis on professionalism, ethical behavior, and the need to focus on personal and professional development. Even this trend has not quite captured the need for social accountability and the importance of the professional being aware of the concept of equity and social justice as a primary condition of human development. I'm happy to note, however, that the objectives of the Good Intern program, which some of you would be doing soon before commencing internship, include enhancing accountability and equity. I'm aware that my audience today consists of a mixture of management graduates, medical graduates, and graduates in allied health sciences. Although it is directly pertinent to the latter two, I hope even the management graduates would consider some of the core concepts that I would deal with in my lecture as relevant to them. Before getting into definitions of social accountability, social justice, and equity, and how they differ from equality, egalitarianism, and socialism, the last of which many people use as an umbrella term to cover all these concepts, I would like to illustrate the concept of equity and social justice with two events from my life. I think they resonate with the theme of my talk today. At the age of 16, as an idealistic high school student, a verse written by a fellow student to the school magazine captured my heart and mind. And actually, I remember it by heart up to date. It was written by the late Padmal de Silva, who subsequently became the academic lead of the clinical psychology program at the Institute of Psychiatry, London. Sampata satuta hasana suma tibena tena amihira andura sangavi gena sitinu dena Devi devata uni mage sita negena pena Vimasa bala nisi pilituru kiyanu mena Minisat bave ek ayurin upatalada Dedeneku ekaku maharaja viman meda Aneka duk vindi podi pel pataka hinda Ei me venasa mata tora kiyana vada The passion for an egalitarian society or a samasamajaya which motivated me then has not dimmed yet. But I have become more pragmatic about the means of achieving it, and also I am much more realistic about the degree of equality that is desirable. You will appreciate this more when I talk about the difference between equity and equality and between social justice and socialism. I am now convinced that it is the responsibility of those more fortunate in life to seek a remedy for this disparity. Bill Gates has echoed this view when he addressed the Harvard's graduating class in their convocation address in 2007. I quote, "Humanity's greatest advances are not in discoveries, but in how these discoveries are applied to reduce inequity, whether through democracy, strong public education, quality health care, or broad economic opportunity. Reducing inequity is the highest human achievement." Close quotes. More recently, I had the opportunity to do a study tour of the health system of Cuba. In spite of the embargoes and trade barriers for nearly 30 years, they have managed to provide high-quality health care in an equitable manner to their whole population, utilizing locally developed infrastructure and health manpower. Their health indicators compare favorably with the best in the world. This was epitomized to me when I visited the hemodialysis unit of their Institute of Nephrology. Through a network of such units, every patient with end-stage renal failure in Cuba has access to hemodialysis when they need it, without having to wait and without having to incur any personal cost. And I saw retired university professors, political leaders, and manual workers being dialyzed side by side in the same unit. Although I could not come to a judgment as to the success or failure of socialism during my short stay in Cuba, I was convinced that its citizens had equitable access to high-quality health care. Now that I have confused you even more than you at the start, let us get down to basic concepts and definitions. Social accountability refers to being held to account by society. That is, having to be answerable to society whether you have fulfilled your role satisfactorily. It is a concept that is usually applied to institutions such as universities and medical schools. Medical schools, for example, have the obligation to direct their education, research, and service activities towards addressing the priority health concerns of the community, region, and the nation that they have a mandate to serve. However, the same concept can be applied to individuals in respect of their role in the community. A doctor, a nurse, or a teacher has to be socially accountable. The core values of social accountability are quality, relevance, equity, and cost effectiveness. All four are equally important, but unfortunately, in the competitive, professional, and corporate context, greater emphasis is always placed on quality, and equity is often completely ignored. In my talk today, it will be the reverse. Let us consider each of these core values in respect of a health professional. Quality means fitness for purpose. This would, to some extent, depend on the training that you have received in the university or medical school. If you have been well trained, you are more likely to be capable of delivering high-quality health care. Intrinsic factors such as your own personality, ability, and attitude are the other determinants of quality. There are differences in quality of care provided by graduates of the same medical school. You have an obligation to maintain and enhance your quality through continuing professional development and on-the-job training where relevant. It is up to you to seek opportunities for training and to make maximum use of such training. To take a simple example, if you are a pediatric house officer, that's my specialty, it would be essential for you to get hands-on training in neonatal resuscitation. That is, resuscitating a newborn baby who does not breathe at the earliest opportunity. I know that it is provided very early, so you have to grab that opportunity. And feedback from your performance appraisals need to be taken constructively and any deficiencies corrected. If you take on responsibilities for which you have not been fully trained, such as a young doctor undertaking part-time general practice while doing a hospital job such as a medical officer in a specialized unit, it is preferable to seek mentoring from a senior practitioner, from the College of General Practitioners. You could also do the MCGP training, which is during weekends, conducted by the CGPSL, or the College of General Practitioners of Sri Lanka. I'm doing this advertorial purposefully because the CGPSL will provide a suitable senior general practitioner from the area that you are working in, who will act as your mentor during your training. This is a uniquely unselfish initiative by the College of General Practitioners, which deserves wide publicity. Relevance in a given context is the ability, relevance is the second important core principle of social accountability. Relevance in a given context is the ability to address the most important problems first. You become more relevant by identifying the priority health needs of the community that you're serving and sharpening your own skill to match them. If you are in a managerial role, like being a medical officer in charge of a hospital, improving the physical resources and infrastructure in a relevant manner is also a means of improving relevance. On the 10th anniversary of the first batch of graduates from our faculty, I think members of the academic staff will remember, we were able to identify such medical officers and felicitate them along with those who had become medical specialists. Relevance of a health professional's skills and competencies to the community that he or she is expected to serve is of course very much a determinant of the curriculum of the training institution. It is a feature of the medical school's social responsibility. That is, it is a feature of the medical school to train graduates who are relevant to that society. However, as we are functioning in a global free market, there is a widespread feeling that our graduates need to be globally relevant. While that is true, unlike a producer of a commodity such as ready-made garments, it would be a mistake on the part of a national university to train its graduates for the export market only. It would be our duty to ensure the right balance between global and national relevance. Now the third feature of social accountability, cost effectiveness. Cost effectiveness is a desirable attribute of healthcare. This means maximizing the impact with the least possible consumption of scarce resources. It is an essential attitude which needs to be ingrained into a health professional. This applies especially to the use of diagnostic tests and medications. In public health interventions like screening and immunization, it's a mandatory consideration. The most cost-effective alternative must be used when treating patients. Health promotion and disease prevention measures are preferred as cost-effective alternatives in conditions like the non-communicable diseases, where the curative measures tend to be very cost-intensive. The health professionals' concern for cost-effectiveness should be irrespective of who pays the bill, the state, the patient, or the insurance company. There are some unscrupulous doctors who inflate their charges when insurance cover is available. This is an unethical practice. The Sri Lanka Medical Association Declaration on Health gives clear guidelines on this aspect. It emphasizes the need for the doctor to discuss the financial implications of the management plan or the treatment with the patient when the patient is paying for it out of his pocket or through an insurance scheme. The relevant section is given below. I'll read it. The people have the right to expect that fees that are charged from patients for services rendered are reasonable. People are entitled to receive relevant information on one's illness, its principal complications, available methods of investigations, that means the test and treatment, their advantages, disadvantages, and costs. How many patients who consult a medical specialist today truly receive this in the 5-minute consultations that have now become the norm rather than the exception? The fourth core value of social accountability is equity. The real thrust of my talk today, equity. Equity is defined in terms of health as the absence of potentially remediable systemic differences in one or more aspects of health or related to health across socially, economically, and demographically defined populations, groups, or subgroups. I know it sounds very complicated. Margaret Whitehead offered a more easily understood definition of health equity. Namely, health equity means the absence of differences in any indicator of health that are not only unnecessary and avoidable, but in addition are unfair and unjust. Equity is not the same as equality. As we know, absolute equality in all aspects pertaining to health indicators is neither feasible or even desirable in some instances. A good example is the slight advantage in life expectancy that females in developed countries have over their male counterparts. This is mostly biologically determined and is not considered an inequity. The females in developed countries live a little longer than the males. However, when females in developing countries have lower lifespans than their male counterparts, this is mostly due to social, cultural, and economic reasons. It is not only correctable by the right intervention, it is clearly unfair and unjust, and it is considered an inequity. In the book that you have with you, there are two bar diagrams which clearly depict what is meant by inequity. These are global data that is presented here. The first bar diagram shows the vast differences in life expectancy in different regions of the world. As you can see, sub-Saharan Africa, it is less than 1/3 the life expectancy in the developed world. And as you can see, the two bar charts are of different periods, 1970 up to 2020. South Asia, we have seen a remarkable improvement from a very low level. But sub-Saharan Africa is the same. Whereas in Central and Eastern Europe, the ex-communist countries, there is in fact a decrease in their life expectancy. So this is a clear inequity. Now, if you look at the next bar diagram, that shows the difference between the top quintile, is it the quintile or the decile? Yes. Yes. The economic quintiles, the upper quintiles and the lower, the gray and black. And as you can see, in every aspect, antenatal care, oral rehydration, immunization, medical treatment for acute respiratory infections, attended deliveries, medical treatment of diarrhea, in every aspect, there is a vast difference between it being available to the richer people compared with the poorer people. These global data from 50 countries, although I have not included it here, I am very proud to say that when it comes to Sri Lanka, these bar charts are almost equal. Almost equal, and in fact in one, the poorer people actually are getting a better service than the richer people. That is in the family planning services. This is a global thing to demonstrate what health equity is. Now, so the bar charts are self-explanatory to explain the concept of equity. Though the need for healthcare systems to address these glaring inequalities is apparent to anyone, one may wonder how the concept of tackling inequities or promoting equity operates at the level of an individual health professional. You might think these are public health measures, or how can an individual health professional enhance equity, or what is his role in equity? I think I will demonstrate this to you through several case scenarios. Now, these are totally imaginary, and any resemblance to any living person is purely coincidental. So they are very brief. Now, the first one, you are the medical officer of a rural hospital, and your usual practice is to do a quick round of the inpatients, then attend to the administrative tasks, and then adjourn to your quarters for lunch, leaving the outpatients to be seen by the assistant medical practitioner or the AMP. In the afternoon, you do your busy private practice, dispensing a much better selection of drugs than is available in the hospital pharmacy. Even if these drugs have been brought privately, this is a very inequitable situation. The poorer patients have not only been denied your clinical expertise in their outpatient consultations, as well as access to an adequate range of drugs. The latter could even be the result of your administrative inertia. This theme could occur in various settings, including in a tertiary hospital, where there are some consultants who could do a selective round of their private patients or give them priority in their operative lists. These instances, though relatively uncommon, do occur and seriously compromise equity in healthcare provision. Another case scenario. You are a Sinhalese doctor working in a predominantly Tamil-speaking area. You have not made any effort to improve your spoken Tamil and continue to take histories from the patients in Sinhala using anybody available close by as an interpreter. Now, this is also a clear instance of an inequity. All doctors should ideally be bilingual in respect to the two national languages if an equitable service is to be provided. Again, I am very glad to note that this aspect is now being addressed in the pre-internship training. Third example. Although roughly 40% of the patients in your part-time general practice are children, you still don't have a children's cuff to measure blood pressure. There. This too is an inequitable healthcare. If you embark on a part-time general practice to supplement your income, not only should you enhance your professional competencies appropriately, you should provide the minimum required clinic setting for ambulatory care. Now another case scenario from a different background. You are a second-year student nurse doing a clinical attachment in an orthopedic ward. Your group of 6 have been instructed to give a bed bath daily to all the bed-bound patients, the patients who are unable to get off the bed for some reason either. However, the sister in charge has told you that the long-standing patient in the last bed, who is a tree cutter by his job, who had suffered a cervical spine fracture and now has quadriparesis, that is weakness of all his legs. He can't move his arms and legs, that he needs to be given a bed bath only twice a week, as the procedure is cumbersome. I will not say anything more. I'll go on to the next case scenario. You are a senior physiotherapist in a physiotherapy department of a busy teaching hospital. Your department is extremely busy with both outpatient and inpatient referrals for physiotherapy. Your usual practice is to complete the physiotherapy procedures for the more demanding ambulatory patients before attending to the inpatients referred from the wards. Most of the inpatients being neurological disabilities like stroke. They are kept waiting on their trolleys and wheelchairs outside your unit till the ambulatory patients are dealt with. So in both these situations, the last two scenarios highlight the relatively inequitable manner in which chronically disabled patients are treated in our acute care focused hospitals. The patient of these, the disabled patients, especially in the state hospitals, tend to be from a lower social class and have a few to advocate their cause. They don't have a voice for themselves. I hope I have made my point. Doctors and other health professionals need to be equity conscious. They have to be fair and just in the way they provide their services. Doctors and medical students have been very vociferous recently on the need for equity in educational opportunity. They are on the roads expressing the need for this equity. But they need to think in the same way regarding access to health care. Let me wind up now by returning to my credo. Equity and social justice are paramount for well-being in any society. After the fall of the Iron Curtain and the demise of communism, the predominant societal model that is pervasive globally is the market economy. now euphemistically referred to as the knowledge economy by the World Bank. Actually, it's the only show in town in the whole world. Socialism, by its old definition, as a society in which the state controls the means of production and distribution, is virtually non-existent. But however, even in this context, the most ardent advocates of the market economy have to concede the need for regulation by the state of vital services like health and education, which are referred to as public goods. Karl Polanyi, a well-known Hungarian economist, said, I quote, "To allow the market mechanism to be the sole director of the fate of human beings and their environment would result in the demolition of society." I think we see proof of this in the global consequences of climate change. Everett Koop, the US Surgeon General, which means like the Director General of Health Services in the US, is on record as follows. While I am a believer in the free market, I have some real reservations about the ability of the market forces alone to do what is best for the health of the American people. The WHO Commission on Social Determinants of Health, which was chaired by Professor Michael Marmot and had as a member Professor Amartya Sen, the Nobel laureate in economics, has concluded that unless we improve the circumstances in which people are born, grow, live, work, and age, by tackling the inequitable distribution of power, money, and resources, which are the structural drivers of the conditions described above, it would be unrealistic to expect a real improvement in health. It recommends developing a health workforce that is trained on the social determinants of health and is capable of raising public awareness of the social determinants of health. That's what I am doing today. There may be some who still wonder why we as doctors or other health professionals need to be so concerned about social justice and equity. I think this was very nicely answered by Dr. P.R. Anthonys, one of the most, if not the most eminent surgeon in this country, when he was interviewed by a journalist on his 50th anniversary as a surgeon. He said, I quote, "I owe everything that I have achieved in my professional life to the poor people of this country. It was by operating on them in the government hospitals that I acquired and honed my surgical skills, and it is that experience, thus gained, which made me what I am today." Another doctor we can emulate with pride is Professor Senaka Bibile, a doctor well ahead of his time, a doctor who was not commercially oriented, a doctor who viewed medicine in terms of service to the people, and a doctor who was courageous and successful in the pursuit of medical reform in the social interest. So, graduates of medicine, allied health sciences, and management sciences, I wish you all the best for your future and success in your careers, but I hope the concepts about the need for equity and social justice will remain with you, the concepts that I have been talking about now. Let us live by the words of Marcus Tullius Cicero, a Roman philosopher and statesman. In nothing do men more nearly approach gods than in giving health to men. And by the Dhammapada, Arogya Parama Labha Santutti Paramang Danang. Health is the greatest gain, contentment is the greatest wealth. Thank you very much.